This is the ECG of a 62-year-old man. He was referred to hospital by his GP because he has had a severe central chest pain 48 hours earlier. The pain had lasted about 3 hours. Previously, he had been well, and by the time he was seen, he was pain free and there were no abnormalities on examination. This ECG shows sinus rhythm, normal PR interval, normal axis, QRS complex as Q waves in lead 2, lead 3, AVF, ST segment isoelectric, T waves inverted in leads 2, lead 3, AVF. What does ECG 3 show? The Q waves in lead 3 and AVF together with the inverted T waves in these leads indicating inferior myocardial infarction. Since the ST segment is virtually isoelectric, that is at baseline and not elevated, the infarction is old. The ECG can show this pattern at any time after the 24 hours following the infarction. So timing the event is not possible from this ECG. Let us see how to localize the infarct. Localizing infarct, two major systems of blood supply to myocardium, as we all know, that is one supplying the right side of the heart and the other to the left side. The right coronary artery, RCA, runs between right atrium and right ventricle and swings around the posterior surface of the heart in most persons. It gives a descending branch that supplies AV node, which is the toll gate of the heart. The left main artery divides into LAD and LCA, left anterior descending and left circumflex artery. LAD supplies anterior wall, most of interventricular septum. The LCA runs between the left atrium and left ventricle, supplying lateral wall of left ventricle. In about 10%, it gives a branch to AV node. So the myocardial infarction can be inferior, lateral, anterior, posterior. The combinations can be anterolateral, infraposterior. Almost all MI involves left ventricle as it is the muscular chamber doing most of the work, so it is more vulnerable to a compromised blood supply. Let us see the ECG changes of MI in leads facing infarction. 1. Inferior MI, diaphragmatic surface of the heart, often by occlusion of right coronary artery. So we note changes in lead 2, lead 3, AVF, that is inferior leads. 2. Lateral myocardial infarction involves left lateral wall, most often due to occlusion of left circumflex artery. So changes in left lateral leads, lead 1, AVL, V5, and V6. 3. Anterior myocardial infarction, anterior surface of the left ventricle, usually by left anterior descending occlusion. Changes in any of precardial leads, V1 to V6. Occlusion of left main artery causes extensive anterolateral myocardial infarction, showing changes in leads 1, AVL, most or even all precordial leads. 4. Posterior myocardial infarction, posterior surface of the heart by occlusion of right coronary artery as no lead supply posterior wall. We have to look at reciprocal changes, that is in anterior leads, especially V1. We have to note that coronary anatomy may vary markedly among persons and precise vessel involved may not always be what one can predict from ECG. We have had a bird's eye view of localizing myocardial infarction. Let us see how to manage this patient. The clinical history suggests that the infarction occurred 48 hours earlier. This patient has presented too late for immediate treatment of the infarction by thrombolysis. Plan for coronary angio and manage accordingly angioplasty or CABG. Aim of management is to prevent a further infarction, and you will need long-term aspirin, a beta blocker, an ACE inhibitor, and a statin. We will go on to next case. This patient, that is case 4 ECG. This is an ECG of 78-year-old woman came with complaints of attacks of dizziness for the past 1 year. She used to have infrequent spells of dizziness, but could come on any time without obvious precipitating events, and they could occur whether she was standing or lying down. She had never had chest pain, and apart from these attacks, she was very well and fully active. On examination, regular heart rate of about 40 per minute, but no other abnormalities. This ECG shows sinus rhythm, alternate conducted and non-conducted beats, normal PR interval in the conducted beats, left axis deviation, tall R wave in lead 1, and deep S waves in lead 2 and lead 3. Wide QRS complex, duration 160 milliseconds, RSR dash pattern in lead V1. Let us analyze the ECG4 further. The alternating conducted and non-conducted P waves indicate second-degree heart block, and this explains the slow heart rate. The left axis deviation shows that conduction down the anterior fascicle of the left bundle branch is blocked, and the RSR dash pattern in lead V1 indicates right bundle branch block. How do you manage this patient? This patient clearly has severe disease of her conduction system. Both bundle branches are affected, and the second degree block probably results from the disease in her, that is, his bundle. The attacks of dizziness may be due to further slowing of heart rate with the same rhythm, or may be due to intermittent complete heart block, that is, Stokes-Adam attacks. This can be investigated with a 24-hour ambulatory ECG recording, but this is not really necessary as she needs immediate permanent pacemaker. Let us have a heart block poem, that is a quatrain. I have created a quatrain is a stanza in a poem that has exactly 4 lines. If P, partner, is unusually far, then you have first degree heart block. If P, partner, reach long, longer, longest, drop, then you have second degree block, that is Mobitz type 1, Venki back. If P, partner, reach or suddenly drop, then you have second degree heart block, Mobitz type 2. If P, partner, quacks Q, dissociating P bar QRS, then you have third degree complete heart block. We will go on to next case. Case 5. This is an ECG from a 70-year-old woman whose main complaint was lethargy. For the past year, she had been breathless and had had some ankle swelling, and she had been taking tablets for this. She felt sick and had lost a little weight. On examination, irregular pulse and signs of mild heart failure. This ECG5 shows atrial fibrillation, normal axis, normal QR complexes, downward sloping of ST segments, best seen in leads V4 to V6. U waves best seen in lead V2. Atrial fibrillation is normal, regular, coordinated, sequential rhythm of atria is lost. What does ECG5 show? This completely irregular rhythm with the narrow QRS complexes must be due to atrial fibrillation, even though the usual baseline irregularity is not very obvious. The downward sloping of ST segments indicate that she is taking digoxin, which explains the good control of the ventricular rate. With untreated atrial fibrillation, the ventricular rate would usually be rapid, and the U waves suggest hypokalemia. In lead V5, the downward sloping of ST segment have arrowed it. How do you manage this patient? In case this patient who is taking digoxin feels sick, she is probably suffering from digoxin toxicity, and hypokalemia may be the main cause of this. Hypokalemia is likely to occur if a patient with heart failure is given a loop diuretic without either a potassium retaining diuretic or potassium supplements. The serum potassium must be checked urgently and appropriate action is to be taken. Remember, a full diagnosis is not made. What is the cause of atrial fibrillation? Most cardiac conditions can be associated with atrial fibrillation, but in elderly patients, the important disease to remember is thyrotoxicosis because atrial fibrillation may be the early manifestation of this in the elderly.